Welcome to the deep dive. Our goal today really is to equip you with those critical insights, the numbers, the nuance, everything you need for consultant level thinking in venous disease. We're not just reading abstracts here, we're getting into the core evidence.
That's right. We're focusing on four absolutely key trials: ATTRACT, ESCHAR, the comparative data around class, and EVRA. Think of it as the essential toolkit. And yeah, it's about knowing the numbers, but also why they matter, how to appraise them critically. That's what makes the difference.
Exactly. It's more than just remembering a p-value. It's understanding the clinical weight, the trade-offs. You need to be able to justify your decisions based on this evidence. Okay, let's unpack this. We'll start on the acute side, DVT management. Let's talk ATTRACT.
Right, ATTRACT. The acute venous thrombosis, thrombus removal with adjunctive catheter-directed thrombolysis trial. Fundamentally, it was driven by, well, the significant burden of post-thrombotic syndrome, PTS.
A huge problem for patients.
Huge. The idea was simple. Could aggressively clearing the clot early, going beyond just anticoagulation and compression, actually prevent that long-term disability?
Because PTS can be devastating, right? Historically, rates up to 70% in some groups really impacts quality of life. So the hypothesis was, get the clot out early with PCDT, pharmacomechanical catheter-directed thrombolysis, and you reduce the risk, especially in those extensive DVTs.
Precisely. Especially iliofemoral DVT, which we know carries the highest risk for severe long-term problems. The thinking was prevent the valve damage, prevent the residual obstruction, prevent the chronic venous hypertension that causes all the symptoms later on.
Okay, let's nail down the PIEO. The study design itself, what defined ATTRACT?
It was a big one. Multi-center, open label. Important point, open label. Randomized controlled trial, around 692 patients. Key inclusion was acute proximal DVT, so symptoms for 14 days or less.
And the comparison?
Straightforward. Intervention arm got PCDT plus standard care anticoagulation compression. Control arm got standard care alone, and they followed them properly for 24 months. Rigorous follow-up.
Okay, the results. The crunch numbers that really drive practice. Primary efficacy outcome. What was it and what did they find?
This is the big one, often misunderstood. The primary outcome was the incidence of any PTS, defined using the Villalta score, so a score of 5 or more, or having a venous ulcer. And the headline result, no statistically significant difference.
So no difference at all?
None statistically. It came out at 47% developing PTS in the PCDT group versus 48% in the standard care group at 24 months. The risk ratio was about 0.96, p-value 0.56. So yeah, essentially no difference on that primary endpoint.
Right. So consultant level takeaway number one, routine PCDT doesn't stop people getting PTS overall. But there's always a but in these trials, isn't there?
Yeah.
There was a finding related to the severity of PTS. Tell us about that.
Exactly. This is the critical nuance. The intervention did significantly reduce the development of moderate to severe PTS, defined as a Villalta score of 10 or more, or an ulcer. Basically, the really disabling end of the spectrum.
Okay, and the numbers there.
The incidence dropped from 24% in the standard therapy group down to 18% with PCDT. That difference, that 6% absolute reduction, was statistically significant. The RR was 0.73, p-value 0.035.
Okay. An 18% versus 24% rate for the bad stuff. That is potentially meaningful for an individual patient facing years of symptoms, but everything has a cost. What was the major safety issue, the trade-off?
Bleeding, that's the major downside. Major bleeding within the first 10 days was significantly higher in the PCDT group.
How much higher?
Nearly 5 times higher. It was 1.7% in the PCDT group compared to just 0.3% in the standard therapy group. P-value 0.049, just squeaking in, but definitely a signal.
Okay, let's frame that. A 1.7% risk of major bleed versus 0.3%. To potentially prevent moderate to severe PTS in 6 out of 100 patients, you're causing maybe 1, possibly 2, major bleeds requiring intervention in those same 100 patients. That's a tough balance.
It absolutely is.
Right.
And that's why it forces really strict patient selection. You're not going to offer this routinely. You're exposing a lot of people to that increased bleeding risk for a benefit seen in a smaller subset. It immediately tells you why guidelines are cautious.
Right. So the ESVS guidelines, for instance, they don't recommend routine CDT.
Correct. Not recommended routinely. It's reserved very selectively.
So who does get it? How do you define that patient where the 1.7% risk might be acceptable?
It comes down to a few factors. One, the extent of the DVT really needs to be extensive iliofemoral disease, not just popliteal femoral. Two, the severity of symptoms. We're talking patients with really marked limb swelling, pain, maybe even phlegmasia where the limb is threatened. And three, crucially, they must have a low baseline bleeding risk. No recent major surgery, no trauma, no active cancer, no bleeding disorders.
And it's an MDT decision, I assume?
Absolutely. Needs a multidisciplinary discussion.
Yeah.
You're weighing up the potential benefit against a definite increased risk. It's not a straightforward call.
Let's think about a vignette. A 35-year-old, otherwise healthy, presents with their first DVT. It's iliofemoral, quite swollen, painful. Phlegmasia ceruleus dolens, maybe? Prime candidate?
Potentially, yes. That's the sort of patient where you'd have the conversation.
And what do you tell them? How do you explain the benefit versus the risk?
You have to be very clear. Explain that the procedure might not stop them getting any PTS symptoms down the line. That overall risk reduction wasn't proven. But it might reduce their chance of developing the really bad disabling form, the moderate to severe kind. You quote the numbers? Maybe 18% chance with the procedure versus 24% without. And you immediately follow up with the bleeding risk. Explicitly state the roughly 1 in 60 chance, or 1.7%, of a major bleed needing treatment. That's informed consent.
And the critical point for anyone discussing this trial, say in an exam or clinic?
It's differentiating those two outcomes. Don't confuse incidence of any PPS where there was no benefit with the severity of PTS where there was a modest benefit. That's the trap.
Any other points from a T-track secondary outcomes?
Well, it did show some short-term benefits. Patients in the PCDT group reported less leg pain and swelling in the first month, up to about 30 days, which, is good for the patient experience initially, but doesn't change the long-term PTS picture overall.
Okay, so wrapping up, atrecty.
In summary, atrecty demonstrated no reduction in the overall incidence of PPS, but showed a modest benefit in reducing the severity of PTS, specifically moderate to severe PPS, dropping from 24% to 18%. However, this was balanced against a nearly 5-fold increase in major bleeding risk within 10 days, 1.7% versus 0.3%. I apply this by reserving PCDT strictly for selected cases of acute, extensive iliofemoral DVT presenting with severe symptoms like phlegmasia in patients with a low bleeding risk and always after MDT discussion.
Okay, let's shift gears completely. Moving away from acute DVT now into the chronic venous world. Specifically, venous leg ulcers, C5, C6 disease. And the huge problem here isn't just healing them, it's stopping them coming back. Recurrence rates are notoriously high.
Dismally high. Often over 50% within a few years if you only use compression. So ESCHAR was really the foundational trial looking at this specific problem. The question was fundamental. Once you've healed an ulcer, does treating the underlying superficial venous incompetence actually prevent it from recurring?
Right. ESCHAR effect of surgery and compression on healing and recurrence, a pragmatic trial, wasn't it?
Yes, pragmatic RCT. About 500 patients, give or take, included patients with active or recently healed venous leg ulcers, and set out to establish that principle. Fixing the superficial reflux is key to keeping that ulcer healed long-term.
Okay, the design specifics, what was compared?
It was straightforward. Compression therapy alone versus compression therapy plus superficial venous surgery. Back then, that meant high ligation and stripping, usually the great saphenous vein, and they followed patients for up to 4 years to look at that key outcome, recurrence.
Now, a critical distinction you mentioned earlier, ESCHAR was about recurrence, not healing speed. Did the initial surgery actually make the ulcers heal any faster?
No, it didn't. That's a common misconception. The healing rates were actually very similar in both groups. At 3 years, something like 89% were healed in the compression-only group versus about 93% in the surgery group. No significant difference there. So the value of the intervention tested in ESCHAR is purely about what happens after the ulcer is healed.
Right. So let's focus on that long-term recurrence prevention. What were the headline figures there? This is the trial's main legacy, isn't it?
Absolutely. This is the key finding. Adding surgery significantly cut down recurrence. At the 4-year mark, the recurrence rate in the compression alone group was around 56%. High, as expected. But in the group that had surgery plus compression, it dropped dramatically to about 31%.
Wow, 56% down to 31%. That's a massive difference. Highly significant.
Highly significant, yes. P-value less than 0.01. A really robust finding.
Can we translate that into an NNT, number needed to treat?
Yes, the NNT to prevent one ulcer recurrence over that 4-year period was approximately 4.
Only 4.
Just 4. Treat 4 patients with superficial surgery after their ulcer heals, and you prevent one of them from getting another ulcer within 4 years. Think about the impact of that quality of life.
Yeah.
Healthcare costs. It's huge.
And the guidelines must reflect this strongly.
They do. The ESVS guidelines, for example, recommendation 77 is crystal clear. It's a Class I recommendation based on level BC evidence from ESCHAR and subsequent studies. It basically says treatment of incompetent superficial veins is mandatory in patients with healed venous ulcers, so C5 disease, specifically to reduce the risk of recurrence.
So it's not optional, it's standard of care.
Standard of care. If you have concerned superficial incompetence underlying a healed ulcer, it needs treating to prevent it coming back.
Now, what about patients with mixed disease? Superficial reflux and deep venous problems, maybe from a previous DVT. Does ESCHAR tell us anything there?
Yes, that was looked at. The benefit of treating the superficial reflux held true, even if there was coexisting deep venous incompetence, provided it wasn't expensive global deep failure. The principle is, reducing any component of venous hypertension helps. If the superficial system is contributing, fixing it lowers the overall pressure on the skin, even if the deep system isn't perfect. So never ignore the superficial reflux.
Okay. Now, ESCHAR used open surgery, high ligation, and stripping. Practice has moved on, hasn't it?
Completely. The principle established by ESCHAR, treat the reflux to prevent recurrence, is absolutely still central. But the method has changed. Today, we'd almost always use endovenous thermal ablation, EVTA laser, or radiofrequency instead of open surgery.
Why the shift?
Lower morbidity, faster recovery, fewer complications compared to stripping. But the goal is the same. Abolish that superficial reflux identified by ESCHAR as the key driver of recurrence.
Let's consider a vignette. A 60-year-old, ulcer healed, now C5. Duplex confirms GSV reflux. They're in clinic for follow-up. What's the discussion?
The discussion has to be definitive. We've healed your ulcer, which is great, but the scan shows the underlying vein problem is still there. To stop this ulcer coming back, and the risk is over 50% if we do nothing, we strongly recommend treating this faulty vein. You explain the options, likely recommending EVTA based on modern evidence, referencing the ESCHAR principle that treatment is mandatory to prevent recurrence. You quote the risk reduction, 56%, down to 31%.
And the exam pitfall here. What's the common mistake people make when discussing ESCHAR?
Mixing it up with healing speed. The key trap is saying ESCHAR showed surgery makes ulcers heal faster. It didn't. ESCHAR is purely about recurrence prevention in patients whose ulcers are already healed. C5. EVRA, which we'll get to, is this trial that looked at healing speed in active ulcers. C6. You have to keep them separate.
Okay, let's summarize ESCHAR.
In summary, ESCHAR demonstrated that addressing superficial venous incompetence, originally via surgery, significantly reduces venous leg ulcer recurrence from roughly 56% down to 31% at 4 years, with an NNT of about 4. This led to the current ESVS Class I recommendation, Rec 77, that treatment of incompetent superficial veins is mandatory in patients with healed VLUs C5 to reduce recurrence. I apply this by ensuring all my C5 patients with correctable superficial reflux undergo definitive treatment, nowadays preferably using endovenous ablation, to minimize their long-term recurrence risk.
Right, now we shift again. We're moving upstream, if you like, to the C2, C3 population. Symptomatic varicose veins, not ulcers, not PTS, but veins causing ache, pain, swelling, cosmetic concerns. And the big question here was, what's the best way to treat them? This is where we saw that massive shift from open surgery to minimally invasive techniques.
Exactly. The class trial comparison of Ulcers surgery and foam sclerotherapy wasn't the only one, but it was a really important UK-based trial that provided key comparative data. This data, along with other similar RCTs, is what underpins the current ESVS guidelines, strongly recommending endovenous thermal ablation, EVTA, as the first-line approach.
So the guidelines effectively synthesize data from class and others. What were the main arms being compared?
Essentially, 3 main strategies for dealing with truncal reflux, usually the great saphenous vein. 1, traditional surgery, high ligation and stripping, HLS. 2, endovenous thermal ablation, primarily EVLA, endovenous laser ablation, in class, but RFA, radiofrequency ablation, is clinically equivalent, so EVTA.
Yeah.
3, ultrasound-guided foam sclerotherapy, UGFS.
And they looked at effectiveness, complications, quality of life.
Yes, all 3, both short-term and, crucially, long-term outcomes, often out to 5 years in these comparative data sets.
Let's start with effectiveness. How well did each method actually close off the main vein? Anatomical success.
This is where foam really fell short, particularly for main trunk ablation. The data, including class, showed significantly lower closure rates for UGFS. We're talking success rates around 55%, maybe 60% for foam in the long term.
Compared
to much better rates for surgery, HLS and EVLA, both achieving anatomical success or closure rates up around 83% to 85%. So right away, for treating the main superficial trunk like the GSV, foam looks less durable.
Okay. And between the two winners on durability, EVLA and HLS, were there differences in how they failed when they did fail, the recurrence mechanisms?
Yes, distinct patterns. For EVLA, when treatment fails and veins recur, the most common reason is recanalization. The treated vein segment simply reopens over time. For HLS, the classic failure mode, especially after GSV stripping, is neovascularization in the groin. The body basically grows new, often tortuous veins around the ligation site due to the surgical disruption.
Interesting. Different biological responses. Now, the big driver for shifting away from surgery, complications and morbidity, how did EVLA stack up against HLS?
This is where EBDA, including EVLA, really shines. The comparative data, like that from CLASS, showed significantly fewer complications. Let's look at some key ones. Bleeding or significant hematoma, much lower with EVLA, around 1.3% for EVLA versus nearly 4.8% for HLS.
Okay.
Infection.
A huge difference here. Wound infection. Minimal after EVLA, about 0.3%. Compare that to 1.9% after HLS. That's a big deal for ambulatory pathways.
Definitely. What about nerve injury? Paresthesia? That's often a concern with thermal methods.
Surprisingly, perhaps, the rate was actually higher after HLS. The data showed paresthesia rates around 6.7% for EVLA compared to 11.3% for HLS.
Wait, surgery caused more nerve issues than laser. How does that work?
It's the stripping part of HLS. Blindly pulling the vein out can easily damage the adjacent sensory nerves like the saphenous or sural nerve. It's quite traumatic. With EVLA, yes, there's heat, but modern techniques use tumescent anesthesia, which protects surrounding tissues, and ultrasound guidance allows careful positioning. So while there's a risk, it seems to be lower overall than the risk from surgical stripping. Fascinating. So better closure than foam, similar durability to surgery, but far fewer complications. What about long-term quality of life, say, at 5 years?
At 5 years, the data showed that EVLA and modern HLS provided similar improvements in symptoms and overall quality of life. Both were effective long-term. However, UGFS didn't fare as well. Patients treated with foam generally reported significantly worse disease-specific quality of life at 5 years compared to those who had EVTA. That lower anatomical success seems to translate into worse symptoms over time.
And cost effectiveness.
EVLA generally came out as the most cost-effective option in the long run, primarily due to faster recovery, fewer complications, and good durability.
Okay, so this comparative evidence really cements EVTA, laser, or RFA as the Class I first-line recommendation for symptomatic truncal reflux, doesn't it?
Absolutely. That's the clear message from the guidelines based on this type of data.
But foam, UGFS, it's still used.
Yeah.
Where does it fit into the modern algorithm if it's less effective for the main trunk?
It has specific niche roles. It's the technique of choice where cannulating the vein for a thermal device is difficult or impossible. Think about very tortuous veins, maybe recurrent veins after previous surgery or ablation, certain accessory veins, or sometimes for treating incompetent perforator veins. It's a valuable tool for those specific situations. But for a primary straight GSV or SSV, you really have to acknowledge its limitations, that 55–60% closure rate, the poor long-term QOL data. It shouldn't be the first choice there.
Let's do a vignette. 45-year-old, CEAPC2, bothersome varicose veins, duplex shows a straight 7mm GSV reflexing from the junction to the knee. What's the recommendation?
First-line recommendation has to be Endovenous thermal ablation, EVTA. You explain it offers excellent long-term results, similar to surgery, but with a much lower risk of complications like infection or major bruising. You'd mentioned the small risk of nerve irritation, around 6.7%, but frame it against the higher risk with stripping, 11.3%. Foam wouldn't be appropriate first line for this anatomy due to lower durability.
And the exam pitfall. How do candidates trip up on this?
Overselling foam for truncal reflux. They might like its simplicity, but they must state its lower anatomical success rate, around 55%. And the evidence showing inferior long-term quality of life compared to EVTA and surgery for main trunks. Know it's niche, but don't recommend it first line for standard GSV-SSV disease.
Right. Let's summarize the CLANUS context comparison.
In summary, comparison trials like CLASS establish Endovenous thermal ablation, EVTA, as the most balanced treatment for symptomatic truncal varicose veins. It offers similar long-term quality of life to HLS, but with significantly fewer complications, for instance. A major reduction in wound infection from 1.9% with HLS down to just 0.3% with EVA. While UGFS has niche roles, its lower anatomical success, around 55%, and poorer long-term QOL make EVTA the preferred first-line option. I apply this by recommending endothermal ablation as the standard first-line treatment for the vast majority of patients presenting with symptomatic GSV or SSV incompetence, reserving foam for specific anatomical challenges.
Okay, our final trial brings us back full circle to venous leg ulcers. We've talked about recurrence prevention with ESCHAR, But EVRA tackles the other massive issue. How do we get these ulcers to heal faster in the first place?
Exactly. EVRA, the early venous reflex ablation trial, addressed the crucial question of timing. We know from ESCHAR that treating superficial reflex prevents recurrence after healing. But EVRA asked, what if we treat that reflex early while the ulcer is still active? C6, does that actually speed up the healing process itself?
Which has huge implications, right? Faster healing means less patient suffering, reduced healthcare costs, quicker return to mobility.
Absolutely massive implications. Before EVRA, there was uncertainty. Many centers would wait for healing before intervening. EVRA provided that crucial level evidence on timing.
So the PFIO for EVRA design.
Another pragmatic RCT. Around 450 patients recruited, all with active venous leg ulcers, C6, and confirmed superficial venous incompetence on duplex. They compared two clear pathways. One, early ablation, Endovenous ablation, usually EVLA or RFA, performed within 2 weeks of randomization alongside standard compression therapy. Two, deferred ablation, standard compression therapy first, with ablation only offered after the ulcer had healed or if it hadn't healed by 6 months.
And the primary outcome was?
Time to ulcer healing, healing velocity.
Okay, the key finding. Did early ablation work?
Yes, unequivocally. Early ablation significantly accelerated ulcer healing.
What were the numbers, the median healing times?
The difference was striking. Median time to ulcer healing in the early ablation group was just 56 days. In the deferred ablation group, it was 82 days.
Wow, 82 days down to 56 days. That's almost 4 weeks faster on average.
Exactly. A 26-day reduction in median healing time. Highly statistically significant. The hazard ratio for healing was about 1.42, with the p-value of 0.001. Very strong evidence.
Were there other benefits to intervening early?
Yes, several. The proportion of ulcers healed by 24 weeks was higher in the early group, about 86% versus 76%. Patients in the early group also experienced significantly more ulcer-free days over the year, roughly 306 days versus 278 days. And importantly, early ablation was also associated with a lower rate of ulcer recurrence during the follow-up period. Plus, subsequent economic analysis showed it was highly cost-effective.
So faster healing, more time, ulcer-free, less recurrence, and cost-effective. That sounds like a paradigm shift.
It absolutely was. EVRA essentially established the heal and seal early approach as the standard of care.
What does this mean practically for a VLU service? What's the pathway now?
It mandates urgency. A patient presents with a new venous leg ulcer. They need urgent duplex ultrasound assessment, ideally at that first visit or very soon after. If significant superficial reflux is found, and it usually is, they need to be fast-tracked for endovenous ablation, aiming to get it done within that 2-week window, just like in the trial, all alongside starting immediate, high-quality compression therapy. Waiting months for healing before ablation is no longer acceptable based on this evidence.
Now let's connect this back to ESCHAR for critical appraisal. ESCHAR used surgery, mostly after healing, and didn't show faster healing. EVRA used endovenous methods done early and did show faster healing. Why the difference?
Two key factors, as you say, timing and technique. Timing. EVRA intervened early, tackling the venous hypertension while the ulcer was actively inflamed and trying to heal, C6. ESCHAR intervened later, after healing, C5, focusing purely on preventing the next ulcer. Addressing the hypertension early seems crucial for healing velocity, technique. EVRA predominantly used EVTIA, laser RFA, which is much less invasive than the open high ligation and stripping used in ESCHAR. Less trauma, quicker mobilization allows the benefits of reflex abolition to kick in faster without the setback of surgical recovery.
So it's the combination. Hit the reflex early and do it minimally invasively.
That seems to be the key combination that drives the accelerated healing seen in EVRA.
Okay, so the distinction is crucial. ESCHAR, recurrence prevention, treat after healing. EVRA equals healing acceleration and recurrence benefit, treat early.
Precisely. EVRA provided the evidence to mandate that early part. It led directly to the ESVS recommendation 76, another class I, level B recommendation. Early endovenous ablation is recommended to accelerate venous ulcer healing.
Vignette time. A 70-year-old lady, first presentation C6 ulcer, screening duplex shows GSV reflux. What happens next?
Immediate action. Start high compression bandaging right away. Refer urgently for a full venous duplex matting scan. Plan for EVTA within the next 14 days. You explain to her that treating the underlying vein promptly, alongside the compression, is proven to heal the ulcer significantly faster, quoting the 56 versus 82-day difference, and reduce the chance of it coming back. Delaying the ablation is actively delaying her healing.
And the exam pitfall is?
Confusing the two trials. Candidates must clearly state, EVRA demonstrated faster healing, 56 versus 82 days, median, plus recurrence benefits by intervening early in active C6 ulcers. EVRA demonstrated recurrence reduction only by intervening after healing in C5 ulcers and did not show faster healing. Get the timing and the primary outcome right for each.
Okay, let's summarize EVRA.
In summary, EVRA provides definitive level I evidence that early endovenous ablation within 2 weeks significantly accelerates venous leg ulcer healing, median time reduced from 82 to 56 days, and also reduces recurrence, supporting the ESVS Class I recommendation, Rec 76, for early intervention in C6 patients. I apply this by ensuring our VLU pathway prioritizes rapid duplex assessment and facilitates endovenous ablation within that critical 2-week window for all suitable patients presenting with active ulcers. #Chag synthesis of final takeaways.
So we've journeyed through ATTRACT for acute DVT, the class context for varicose veins, and then the 2 key VLU trials, ESCHAR and EVRA. Looking across all 4, is there a common thread, a sort of meta lesson for modern venous practice?
I think there definitely is. The clear theme is the superiority of targeted, minimally invasive interventions applied at the right time compared to older, more invasive methods or just conservative care alone.
Precision, timing, minimizing harm.
Exactly. And every single decision involves that careful consultant-level calculation, weighing the absolute benefit against the absolute risk using the specific numbers from these trials.
Let's quickly recap the strategic pillars for me.
Okay. 1, Tafraxi, acute TVT. Intervention CDT is not routine. It's high risk, 1.7% bleed for relatively low yield overall. No reduction in any PTS. Reserved only for severe, extensive iliofemoral DVT, where reducing the severity of PTS, 18% is 24%, might justify the risk after NDT.
Right.
2, class context, varicose veins.
Yeah.
EVT is the clear winner. Class I recommendation. It matches surgery for long-term QL, but blows it away on complications. Example, 0.3% infection versus 1.9%. Foam is dramatically less effective for truncal veins, 55% success, and has worse long-term QL.
Got it.
3, VLU management. ESCHAR and EVRA. This is a double mandate. Ablation of superficial reflux is essential. EVRA tells us to do it early, within 2 weeks. In active ulcers, C6, to accelerate healing, 56 versus 82 days median. ESCHAR tells us it's mandatory after healing, C5, to prevent recurrence, risk cut from 56% to 31%. Treat early for healing, treat eventually for recurrence prevention.
That really clarifies the VLU pathway. And the ESVS guidelines package all this up, don't they, using that class and level of evidence structure?
Precisely. Those guidelines aren't just opinion. They're built directly on the evidence from trials like these. Using the class level system provides that clear, structured approach. A Class I, Level B recommendation comes with real weight. It tells you there's good RCT evidence supporting that action.
It standardizes care and forces us to justify deviating from the evidence base.
Absolutely. It removes ambiguity and pushes for best practice based on robust data.
This has been incredibly helpful, really drilling down into the numbers and the why behind current practice. Thank you for walking us through that.
My pleasure. It's crucial to have these figures at your fingertips. But before we finish, maybe one final thought to leave listeners with. Something the evidence doesn't yet fully answer.
Oh, a gap in our knowledge. What did the Guidelines Committee flag?
Well, we have brilliant evidence from EVRA about intervening early in new or relatively recent ulcers. Heal and seal early. But what about those really chronic refractory ulcers, the ones that have been open for 6 months, a year, even longer? The ESVS guidelines highlight this evidence gap.
So the question is?
The question is, what is the actual expected benefit of treating superficial venous reflux in a patient whose ulcer has been open for, say, more than 6 months? Does that impressive healing acceleration seen in EVRA still apply when the tissues are so chronically damaged and remodeled? Is the intervention still as effective, or are the returns diminished?
That's a really challenging clinical question. It forces us to think about the chronicity of the disease and whether interventions have a point of diminishing returns.
Exactly. It reminds us that even with landmark trials, there are always nuances and areas needing further research, especially in chronic conditions.
A perfect place to end. A reminder to always think critically about applying evidence to the individual patient in front of you. We definitely encourage you, the listener, to go back to the source papers, look at the PICO, the methodology, really own this data.
Know the numbers, know the context.
Until next time on The Deep Dive, keep questioning, keep learning.